starting 9 minutes before the discussion time of an extra hour for this session ends. I have not been at one BANF meeting where we were on time. So thanks, Kim, for kicking it off today. So I was asked to what can we do? Actually, we heard so much good stuff today. And as you said, I thought it was a stimulating conversation, Kim, or some call it hackling, but there was good progressive discussion. And how do we actually take this to the next level until the next BANF meeting? So, because before the meeting is after the meeting, and after the meeting is before the next meeting. It's like, it's a famous sentence of a German soccer coach. But anyways, so here's some housekeeping about a working group meeting tomorrow for the Digital Spatial Profiling Working Group. So everybody who's interested in spatial resolution of gene expression, show up at 7 a.m. on the second floor in this room 208. Here are my disclosures, and here are my objectives, and I can't read my own slides without glasses. As a medical director from a fairly large-sized clinical laboratory, I would try to share my perspective to understand that validation is needed to include molecular transplant pathology into our routine practice. And I will show how we actually assess tests to add to our test formulary here in Alberta. And of course, I want to achieve some consensus and coordinate some efforts on advancing, and Martin already alluded to that, the useful inclusion of molecular diagnostics into our routine practice, right? What we have learned today, reflecting over 30 years of BANF, is one big strength was that this classification allowed to do multi-center trials across the world using one system, even if it was flawed. For some of you who are pathologists and who, I was trained as a resident, and there was the first clinical trials for malignant lymphoma, and there were 6 different classifications in the world. And they all have the name of some famous pathologist. And I happen to come from northern Germany, so I had to follow the Kiel classification, right? And then there were a Rappaport, and they could never enroll enough patients to do meaningful trials. So that was the biggest success story of this classification. And of course, cancer is leading the way, but there is a subtle but important difference. The big successes in cancer positioned on molecular diagnostics is for monogenetic driver diseases. So you see this, the famous picture here. That's a patient with malignant melanoma. The black dots are all metastasis, and all of us who are a little bit older know when you had a diagnosis of malignant melanoma, before biologic treatments were available, you got 6 months at max when you were metastasized. So, but this melanoma has a BRAF mutation in the EGFR receptor, and there's a drug against that mutation, blocking it and taking away the tumor growth. And after a few weeks of treatment, all metastasis and tumor resolved. But the beauty of this is, this below is a child with a glioblastoma. Same mutation, different tumor, same drug, same effect. Unfortunately, we haven't found that molecule for rejection in transplants yet. Well, Phil, I think you studied all molecules. Anything left we can look for?
Yes, but I can't tell you.
Okay, well, more to come. So the success of targeted treatment based on single driver mutations is probably not applicable to the transplant situation. However, what we did with BANF is we established these consensus arbitrary thresholds where we should treat. And that brought up the possibility for these large multi-center trials, which actually got regulatory approval for MMF and tacrolimus, and with that significantly improved allograft outcomes. So we set a threshold on a continuous disease spectrum. And cancer has done the same, the PD-1 story. So it's rejection the other way around. You reject the tumor, so you want to enhance, by inhibiting PD-1, your immune response to go after your tumor in lung cancer. And the clinical trials were designed to find that threshold for a dose of PD-1 when this drug is effective. So this concept also works in cancer. And we know from, and these are actually, Gunilla, these are your slides from your PhD thesis, just by the way. That's your mouse experiments of day series of where we know T cells go in there and reject. And they don't do it in isografts. So the T cells we see in the graft have something to do with rejection. And Banff, as we learned today, just pushed it to the maximum of having rules how to score this and how to turn this into consensus diagnosis. But as we know, association is not causation, and there's limitations in reproducibility and sampling error and so on. And we know that our cardinal lesions of T-cell mediated rejection, for example, interstitial infiltrate and tubulitis, Mr. Tubulitis, is not specific because there's other diseases causing the same pathology. And Phil showed that the molecules align, and we saw this, with these pathology lesions, and you don't need thousands of molecules. Some are driving this, and they are key representative. And Martin showed you can have the rejection classifier without genes, so almost without genes, with 2 or probably a handful has a similar performance than dozens. But we also know, and Ben Adam did work on this, in the transplant, we have various mechanisms causing inflammation. So he studied where you have the checkpoint inhibitors, the PD-1 story, applied to patients with cancer getting interstitial nephritis, but some of these patients also were kidney transplanted and they rejected. So the literature is full of these case reports. So an advantage of the NanoString platform was we could gather cases from all over our collaborators, and they digged out these rare cases from their archives, and we could study them and compare them to a drug-induced interstitial nephritis using the NanoString. And what we found is there's significant overlap in the inflammatory signal, whether you have interstitial nephritis, checkpoint inhibitor-induced interstitial nephritis in a transplant or in a native kidney, or a standard drug-induced interstitial nephritis. And he compared polyomavirus nephropathy in native kidneys, which do not reject, by the way, and polyomavirus nephropathy, pure TCMR in transplants, and none of the inflammatory genes were significantly different. You only have so many T-cell genes, and when you need T-cells, the genes come up. Similar for antibody-mediated rejection, we understand the mechanisms pretty good today, and there is lots of primate models and animal models where you can simulate this disease, so we have very robust mechanistic insight at the molecular level how antibody-mediated rejection works. And we know which transcripts, thanks to Luis Hidalgo and Phil's work, are associated with DSA. We know it is the NK cell-mediated mechanisms, the endothelial injury, and some inflammatory components. But recently, and we have heard this today several times, is when we see microcirculation inflammation, we know DSA can cause it, and it causes the upregulation of certain molecules. But when we see microcirculation inflammation for other reasons, or we can't detect the donor-specific antibody, we see the same interrelationship. So it again becomes a bit of a semantic question. Can you have antibody-mediated rejection without antibody, or is missing self antibody-mediated rejection, or do we call it something different? But the key relationship is that, as Mark pointed out in his discussion, the pathology we see translates into a molecular phenotype. And it still not necessarily tells us what causes the pathology at the molecular level or at the histology level. So we did, again, an advantage of NanoString is going back to your archives and finding the red herrings. We put together a series of cases which have microcirculation inflammation for various different reasons. And we also digged out glomerulonephritis with microcirculation, with glomerulitis, endocapillary cell, inflammatory cell accumulation. And you see, depending on what genes you look, when you look at ABMR, everything in the transplant, so the key ABMR genes, whether they had DSA or only microcirculation inflammation, some of these are very early post-transplant with DGF and severe microcirculation inflammation, whether you have features of interstitial inflammation and tubulitis, so T-cell mediated rejection, or you have pure T-cell mediated rejection with PTC, severe PTC, but no glomerulitis, they all activate microcirculation injury at the molecular level. Glomerulitis seems to be a little bit less than our normal implant biopsies. Well, when you're a normal, so no histology, all Banff scores are 0. But remember, being brain dead is not normal when you donate. So even that injury causes activation of your microcirculation without inflammation. We have these subtleties that the molecules can pick up pathology, so to say, where we probably miss it in the microscope. But interestingly enough, this similarity of the implant biopsies in the glomerulonephritis was particular for only endothelial genes. So it seems that what we see at molecular associates with ABMR, there is some more information when you break it down into what the transcripts are associated. Is it the inflammatory response? Is it the endothelial response? And the real beauty when we want to do mechanistic studies is now that we can stratify our cohorts to certain phenotypes and compare them even to native kidneys or very rare entities. So, and what I just said is really, this is my favorite paper. I like the colors of the graphs. No, I actually like the content very much because it nicely illustrates our knowledge about the molecules and rejection. There are transcripts which are very, very strongly associated with TCMR phenotypes in the biopsy, others with antibody-mediated rejection. They overlap when you're mixed, and some others come up in the statistics when you have this mixed mechanisms of pathology going on. And these associations, I think, have been shown by everybody working in the field in some form or shape. And Phil also, in full disclosure, showed that these associations overlap between the entity groups, right? So we have the lack of accuracy in whatever regard or angle you want to see it. And Jeff Reeve also showed very early that depending on what math you use and what classifier and what equation, you get certain variants as well and nuances. But these fundamental associations of mechanistic driven molecules with certain pathology phenotypes are actually very robust, and it's all about then thresholds. And the concept then, what the Banff Consortium has is the same as we had for the I-score and the G-score. Banff didn't invent interstitial inflammation or tubulitis, as Kim pointed out this morning. Banff found consensus how we should report it and when we call it too much. And that kind of worked in the clinic, accidentally I would say, or maybe Kim had planned it that way. But it worked, it did advance the field. And maybe we can do it again, but a little bit more smart and more informed. So everybody cited Bob's paper. Bob's not here, great paper. No, Ivy is here. But it is another example where you can now go with that knowledge and look in a targeted manner of these overlapping phenotypes, what differences they have. And that can help us to make informed consensus decisions where the most feasible thresholds potentially are. And we saw a lot about decentralization today, right? Is it the right term, decentralized? You can have 100 commercial labs, and they all do the same, right? Is that decentralized? I think what we are talking about is proprietary solution towards open LDTs or versions of it, which can be used with different technologies and platforms. And that's where I come in as a medical director. Of course, we are always looking, we're in Canada, always looking for a bargain. For us, it's what's the cheapest to get. But there are models of where you can use decentralized testing with centralized normalization. That's a common approach done in clinical labs, you know. You may know that all babies born in many developed countries undergo newborn screening. That newborn screening is a battery of tests together with radiology information and demographics of the mother put in a risk equation calculator run on a centralized server by a company coming from Germany. Most countries use that. And that calculates a risk for certain prenatal diseases. And that triages how women are managed during pregnancy. We recently did an update on that software, and it had one coding error. We had over 1,000 women miscalculated. So there are aspects we in clinical labs think about. So how do you do quality assurance, quality maintenance, sustainability, right? What are your positive controls when you run this decentralized? Or with components that are proprietary and you can't look into it. So what do we need to do, ideally? And that is your homework for this week, because we're coming together on Friday with a summary. And I expect all of you to participate. So as you see in the literature, it's straightforward. You need analytical validity, clinical validity, and clinical utility of a test. So analytical validity, how well does the test measure what it claims to measure? So you have an assay and say, I measure granzyme B mRNA. But when your test measures CD20, your test has no analytical validity. And that usually comes with vendors, reagents, you have positive controls, right? So that you can do that. But as we heard today, what do we need to do to have solid analytical validity across the community with equal access to that testing is? So reproducibility studies and normalization calibration studies are needed. That's what you need to do in pathology all the time when you bring a new test on. And we have professional organizations who send out standard material that everybody calibrates the machines against it. So you all do creatinine in your hospitals, but you probably have all different machines, but there is central reference standards your machines are calibrated against it that they can calculate what they measure into your creatinine to report. So ideally, a nanostring or a PCR or a microarray count in Edmonton needs to be the same as a count in Paris. Ideally, never gonna happen because Paris can't do it right. A nanostring count result of X needs to be convertible into a microarray count of Y and a PCR count of Z. And that is what most clinical tests do. So you might have Roche in your chemistry line, or you have Baxter over there. They all measure different numbers. They all get reconciled for a standard into a 1 for creatinine. And you can also do this for classifiers. An MDX classifier ABMR score needs to be convertible into a BHOT ABMR classifier score, or at least validated defined threshold for relevant clinical interventions must exist for both. So when MMDX calls something ABMR positive, the clinical intervention should be at the same level of evidence as the BHOT classifier calling it positive for ABMR. So there's various ways to achieve this analytical validity. Clinical validity, how relevant is the test measured to the clinical condition? So again, you measure T cell gene sets, but T cells do not play a role in T cell mediated rejection. Well, we know that's not true, right? But we demonstrated this association robustly. So we have done that very well and very large numbers of cases. However, all transplants. So we haven't really looked about the differentials of recurrent disease. Maybe it's not necessary, but we claim that T cells are specific for T cell mediated rejection, but there's other diseases, as we now know, also for the microcirculation inflammation. So we should probably study more positive controls and true negative controls. We have to have enough sample size, which I think is already getting there, but we have to have diverse cohorts. Gender, ethnicity, stage of disease, right, comorbidities. So we haven't really looked at that distribution of the cohorts, whether there is any. And we had questions now here, what's about treatment? And you know your patients are treated and immunosuppressed with who God knows what over time, right? And ideally we would do head-to-head comparisons, right? Same patient, same biopsy, half of the RNA goes on that, half of the RNA goes on that. And you would show that they have comparability, or you can show superior performance on one or the other. Where we not have done much yet, and we're still arguing, is clinical utility. So it's not well defined yet, and when I follow the literature, or try to do, is, and also the conversation is going between, oh, this is diagnostic. No, it's actually associated with outcome. That's because that makes it diagnostic. Because ABMR has a bad prognosis, but we don't know whether prognosis in this patient is bad due to ABMR, or they had recurrent disease, or got BK on top because they got heavily immunosuppressed. So we mix prognostic with diagnostic and try to validate diagnostic due to the lack of a ground truth with prognostic endpoints. It's like saying, well, when you die, I diagnose you with cancer. No, you can also die from other causes, right? So that's the conundrum of not having a ground truth for diagnosis makes it very hard to validate a new diagnostic. So what we need, and that was said by everybody else today, is well-designed either prospective trials testing a defined clinical utility claim. So that the claim cannot be this is better than, but for what in what. And with a nanostring platform, you could retrospectively design these trials because you can go back to the biopsies in the archive. We could ideally, we would go back to the big clinical trials done by pharma and pull all those blocks because the patients were randomized, monitored, standardized with a hard endpoint. You just go back and run all those paraffin blocks and see what it tells you. So ideally, we as a community would somewhat align along these lines and present data in the peer-reviewed domain, checking off these questions and information. So how do you do this usually with a diagnostic test, right? So creatinine or troponin, where you have thresholds and where you have normal ranges, you all read your lab reports, and then you get a number, and then you get reference range, and then when it's red, it's high, and when it's black, it's okay. Right? That's how I read lab reports. So the reference range usually comes from panel A, where you tested 100,000 people of diversity, age, whatever is relevant, and you set the reference range, which has a confidence interval, usually 1 standard deviation. You realize that means that 5% of your normal lab tests are actually abnormal statistically, and 5% of your abnormal are statistically normal. Right? You live with this fuzzy margin of reference ranges, but that's as good as it gets. Or you say there is a clinical relevant action, like high sensitive troponin, prospective trials, chest pain protocols. You measure it all comers in the emergency room on those which dropped dead without treatment by myocardial infarction had too high of a troponin. That's a fairly brutal threshold setting approach. But that's how troponin was narrowed down, right? So when you say, and I run ECGs, and that triggers a clinical action, and that set the threshold for high sensitive troponin in clinical chemistry labs. So where we are here, and ideally, really, we have done a lot of work on analytical validity and clinical validity, and more can be done, for sure, and we identified some gaps today. But clinical utility, we're really, really lacking. And the FDA or regulatory bodies, ideally, so you define, before you do your study, you define the context of use you want to test. So it's not okay, you just test and see what is significant and then say, well, look, I always wanted to show that. So ideally, you either do this before you apply for your IRB and then you go back to the archives, or you do it prospectively for your randomization protocol. And you have two arms. One is with a biomarker or the test, and one is standard of care. And then you randomize in both arms for intervention. And then you look at least for non-inferiority. And a recent paper in the New England Journal did this very elegantly, right? It's a very, very simple approach, I would say. The question here is patients with colon cancer. When you have advanced stage colon cancer, you undergo surgery, and you have a risk of relapse, right? That the tumor comes back because you didn't get all lymph node metastasis, because advanced stage is lymph node positive. And usually you monitor the patient's standard of care with a combination of imaging, endoscopy, follow-up visits. And that was the standard of care arm. And then they are randomized by risk stratification with these factors for neoadjuvant chemotherapy. And neoadjuvant chemotherapy has a lot of side effects, especially in elderly patients. And the other arm had blood-based testing for cancer cell-derived tumor cell-free DNA. So the testing was only based on the blood, and when the patients didn't show a relapse of tumor cell-derived cell-free DNA in the circulation, they didn't get neoadjuvant chemotherapy. And they could show this trial with non-inferiority outcome, so both arms had the same outcome, but they spared many, many, many individuals the aggressive neoadjuvant chemotherapy. So it's not always that your endpoint has to be something better. It can be enough that your test allows you to do less and avoid harm. We can think of different designs in our community around that. So I am also, in my role, the current chair of our laboratory test formulary in Alberta. So we get requests to fund tests. And we have a rapid prioritization framework with all these aspects and checklists what tests are evaluated for. And there is, of course, clinical performance, so clinical validity, the system level need. Do we have an alternative test which is somewhat doing well? Do you have to beat that test, or is there nothing in that space? Then the alignment with the values, mission, and vision of the payer, which might be different from payer environments. Then the system stakeholder engagement is, so do the clinicians actually want the test or not? You would think clinicians want every test, right? Don't you? No, our oncologist said is we don't want that test. We said, oh look, we have this test, it's cheaper than what you have. And they said, no, don't give us that test. So we had no endorsement of certain tests. Systems capacity, does the testing require when you implement it, capital investment, new technologies, new skills, do you need to hire different people? Because that is a factor costing into the upfront cost of bringing a test online. And then of course the health economic impact, affordability, meeting the willingness to pay threshold in our environment, demonstration of cost effectiveness, this is clinical utility, what's the health value added by a test? And the budget impact, where usually we have more requests than we have budget, so we have to rank them by availability per year. And then our patient advocate on the committee strongly focuses on equity, equitable access, and transparency for patient input, whether they actually want to know about test results in their context of disease. So this gives a framework of where a test has to fit in. Ideally, we adopt tests which are cheaper and produce more health, right? We have a lot of tests we do which cost a lot and do not produce any health at best, and some actually do harm, historically, and that's well known, not in transplant isolated, but in medicine. So, up till today, and Dori Segev, I gave this talk and Dori Segev came up to me and said, Michael, so what? I thought, thank you, right? So, what we tell all our residents is, don't order a test when you don't know what to do with the result. Be careful what you ask for. But then you get back borderline. Borderline. But inappropriate clinical utility claims can cause patient harm and unnecessary costs to the system. So over-optimistic expectation to certain tests by whoever, the patients, the providers, clinicians, right, hoping that when we do NGS on the 5th relapse of a cancer, we'll solve the disease. No, probably not, unfortunately. So more precise diagnosis and better risk prediction, but still often we don't have a treatment. So imagine we have the wonderful diagnostic test, and Carrie, you go to your patient and say, we definitely know you have ABMR. And? Well, nothing we can do about it. So is that enough? Ask your patients, right? Is that what we approach? But I still think molecular diagnostics are promising, but we need concerted efforts. We're a small community to focus on randomized, retrospective or prospective, multi-center trials for validation of its clinical utility. So now is the time. I think we have the tools, we have the knowledge, the understanding, we have the brains, some of us have the money. Alex, where are you? Right. So Phil, Alex, you have the deep pockets here to do what I propose. I think we are ready to do the next generation of studies, which are somewhat smarter than just cranking through another 25,000 biopsies, but rather design something which specifically addresses one low-hanging fruit, right? And I would love to see that happen until the next Banff meeting. And because we had a great start here, 30 years we worked through the lesions, and I think this is just the start of taking the classification to the next level, integrating these molecular tools and artificial intelligence tools to give us even better decision support. So with that, I have one very, 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 very important slide to show. And I'm not taking any questions, anybody, if you can. We're just 1 hour and 22 minutes over. Unbelievable. So it's time to celebrate. You may not notice, this is the Banff pre-meeting with an idea born by Denny Glotz in Paris, and there were 25 people, totally jet-lagged, somewhere, and they discussed stuff. And today the room is full for the pre-meeting. This is not even the real meeting. And thank you, Kim, for starting this off. And it is so great to see people like you, Phil, Parmjeet, Brian, who I saw in this room giving talks when I was a resident, right? And it was just fantastic. And I want to just celebrate a few key members who, I don't know, can you retire from Banff? I don't know, somewhat. So Lorraine, of course, retired, seriously retired, and said, I'm not coming, guys. But I think she deserves a lot of credit for the reasons you said, Kim. She wrote the papers when you didn't want to. She put together the program. It was, without Lorraine, we wouldn't have been here. And then there is Ed Krause, who cannot be here, unfortunately, today. And he said also he's likely not come again to a Banff meeting. And I think this picture is everybody who met Ed Krause at a Banff meeting just tells it all. Said, well, when he comes up to the mic, well, I have a question. And then you think, oh my God, no, he got me. And then Mark Haas right behind him, right, those two, were really stimulating to the process and the voice of reason. And thank you, Mark, for writing the meeting reports via email with 300 people giving you feedback. I would not have done that. And Mark also officially retired from being the program chair and handed it over to Martin and Candice and just gave them some advice this year. And I think Martin and Candice, you did a fantastic job in putting the program together. Really great. Thank you, Mark, for doing this for more than a decade. And yeah, give it a round. And still today, you're not holding the microphone close to your mouth, like on this picture. But you had always something very important to say, and without you, the classification would not be what it is. And I thought this picture is really where you walk out the Banff meeting in Barcelona, kind of symbolic. But I hope you come back, we will entice you. And then Daniel Serron, who was also a member of the Board of Trustees of the Banff Foundation, and he also retired. And I don't know, retired into his wine cellar, I think, but in Barcelona. But he told me, I emailed him, and he said he's during the pandemic, he took a degree course in gardening. So he now has completely revolutionized his yard. So I was a bit disappointed that he felt that was more important than going through this meeting. With that, celebrating all this and this day, I invite all of you down to the, or who wants, down to the bar. Bistro, and I'll buy drinks. With that, thank you very much, and welcome to the Banff. If you want, for those who want to stay behind, be with Martin. Those who want to have a drink, come with me.